Hello and welcome to Season 2, Episode 42 of the Physician Assistant Exam Review Podcast. This week we're going to be covering spiders, bugs, and fungal infections. So as we make our way through dermatology, we're covering some of the grosser stuff today. Some of the images you can find, though, are pretty cool if you look some of them up as you go through this material. I stopped linking to images on the website because the links break over time, and to maintain them is a whole nother job. So this stuff is super easy to Google now. If you have questions about the way something looks, for example, we're going to talk about scabies and burrows this week. And I actually just Googled them this afternoon, picked up some images, looked at those, got a little bit better understanding for myself of what those look like, because that's not something I would normally see in my practice. So definitely just Google anything that you have questions about images and how it looks. I think that it might help it stick in your head. Definitely use that as an option for you, because some of this stuff has some really cool pictures, especially with dermatology. This week, we're going to jump right in with our priming questions. So let's go ahead and get started. What are the only two types of spiders we need to worry about for the PANCE? What are the only two types of spiders you need to worry about for the PANCE? What are three types of lice we need to worry about for the PANCE or the PANRE? Three types of spiders we need to, three types of lice we need to worry about for the PANCE. How do you diagnose scabies? A scabies infection, how do you diagnose it? How do you diagnose a scabies infection? And our last one, if you see spaghetti and meatballs in a test question, what diagnosis should that make you think of? If you see spaghetti and meatballs in a test question, what diagnosis should that make you think of? Okay, so we're going to begin with spider bites today. And the only real two that you need to be concerned about for your exam are the brown recluse spider and the black widow spider. Many other spiders have poisonous venom, but for one reason or another, they don't harm humans. Either their jaws aren't strong enough, our skin is too thick, their jaws don't open wide enough, all sorts of different reasons why, although they have toxic venoms, they don't necessarily affect us. The two that will show up on your exam, however, are the brown recluse spider and the black widow spider. We'll go through them in detail, but the main differences, or something important for you to understand here, is that the brown recluse spider has venom that causes that necrotizes tissue, and the black widow spider has a neurotoxic venom. So they're a little bit different from those perspectives. So let's talk first about the brown recluse spider. This is found in the mid-southeastern states. That's going to show up in your test, right? They're not going to give you a person in Canada gets bit by a spider and it's going to be a brown recluse spider. Not going to happen. They want to feed you these terms, these ideas. So the mid-southeastern states, on the website, if you go to www.physicianassistantexamreview.com, click on Blueprint, scroll on down to episode 42, you will find I've linked to a map from an article. I told you in the beginning I didn't link to many things anymore. This one I just checked. It was still there from when I linked to it in the initial article I wrote on spider bites many moons ago. And this is an article that's really good on brown recluse spiders if you're particularly interested. But what I really liked for you guys is that it has a nice map of where you may find these. So here, the bite contains an enzyme that causes cell membranes to break down, leading to significant tissue damage. That's the key here. So our clinical presentation is that the initial bite is usually painless. People don't notice it, but it may become painful after about an hour, maybe 90 minutes. The area of the bite can become pruritic, and the lesion goes through a couple of different phases. It's erythema, blanching, and ecchymosis. So sometimes it's referred to as a red, white, and blue lesion. The most severe cases have to do with either the venom traveling in the bloodstream or a severe allergic reaction. Otherwise, you get local tissue damage. You get local necrotizing of the tissue. So the tissue starts to break down. You get eschars over top of it, and it's that enzyme that causes the problem. So treatment, there's no particular treatment for the bite itself, but you're going to wash it, you're going to keep it clean, and if it needs to be debrided because that tissue is dying, then you need to debride that tissue. Antibiotics may be useful, as a secondary infection is also very possible here. Next, we have the black widow. There are many, many types of widow spiders, but most of them, like we said before, like other spiders, are not dangerous to humans. Clinical presentation for the black widow, the bite is usually painful, and it can be a sharp initially and then a dull, numbing type of pain. The interesting thing here to note is the pain is out of proportion to the bite, so it's significantly painful. More severe symptoms include things like muscle cramping and pain, and more significant pain. You can get hypertension and tachycardia. And then again, even more severe symptoms would be headache, nausea, and vomiting. Treatment here, same as before with the brown recluse spider, it's going to be monitoring that wound and cleaning the site of the wound. But really, there's not much to do at the site here. Opioids and benzodiazepines are for pain. And there is an antivenom available, but that's only reserved for severe cases. So that's about it for spiders. There's, like I said before, there's not a whole lot to know. I think knowing the area on the map where they are located, I think knowing the description that the black widow is a neurotoxic venom and the brown recluse is a necrotizing venom. So having the picture of someone who walks through the door, being able to diagnose these is as far as you're really going to need to go. And if you think about it, there's not a whole lot more to do. The treatments are more or less the same. All right, so derm parasites is next. We're going to start with lice. These are a blood-sucking insect. They're transmitted through close contact. What I didn't realize until I really started going through this more is that there are 3 distinct types of lice. I thought there were just 3 different areas where they may be found, but it's actually 3 different types. You have head lice, which is most commonly found in girls aged 5 to 11. You have body lice, which may be a vector for other diseases like typhus. And also, interestingly enough, with the body lice, they don't live on the person. They live in the bedding or the clothes, where with head lice, they live on the person. And then pubic lice, which also live on the individual. Clinical presentation for head lice is an itching scalp. For body lice, it's severe body itching. And for pubic lice, it's itching of the pubic area. So pretty much straightforward. We have some serious itching going on with lice. Lab studies and physical exam findings. For head lice, you can find these small nits or eggs at the base of the hair follicles. They're white oval-shaped eggs. And then you can use a fine-tooth comb to isolate the organisms and actually visualize them. You may also see excoriations due to severe itching. For body lice, you're going to see you might find linear excoriations all over the body. You probably will not find the actual organism. Again, they don't live on the body. They come to the body to feed, but they live in the clothes or the bedding. You can also maybe see small red bites here from the body lice. And again, with pubic lice, you're going to try to isolate the organisms, and you may see excoriations from the itching. Treatment. For pubic or head lice, the primary treatment is permethrin, 1% applied to the affected area after shampooing and rinsed out. You're going to put this, you're going to re-shampoo with this topical treatment. For body lice, you're actually not going to use any topical treatment because, again, they don't live on the body. So you're going to treat the patient's clothing and bedding. It should be thoroughly cleaned at super high temperatures. And then sexual partners should also be treated in all cases, most likely, but specifically in pubic lice. Scabies is next. These are mites that cause severe itching reactions. And these are easily transmitted from person to person. The clinical presentation here is severe itching as well, so similar to lice. But the most common locations here are a little bit different. It's the web spaces between the fingers. It's the wrists, the waistband, and the genitals. So it might be like pubic lice. It might be a little hard to differentiate between with the others. The area they'll give you will be different. I feel like anytime I see a question on these, it has the web spaces of the fingers, and very few other things present with itching at the web spaces of the fingers, right? So that sort of stands out to me as something like, if I hold on to that, I've got sort of a picture for scabies. Lab studies and physical exam findings, so that you can see these track-like raised burrows. They're linear and pruritic. And on microscopic examination of the skin or burrow scrapings under oil immersion, you can see the organism. Here we're going to do a similar treatment, but it's going to be a permethrin 5% cream. This is the most common treatment. And you're going to apply it to the entire skin surface and then wash it off in the morning. So slightly different, same medication. And there's a whole bunch of these. I just gave you the most common one. I don't think you will see, I'd be surprised if you saw the actual name for the treatment of these on there on your exam. It's possible, but it seems unlikely to me. I think it's much more likely you'd have to pick out from either an image what these look like. You'd get a question like, person comes in with severe itching at the web spaces of their fingers, that sort of thing, and then you'd have to diagnose it. I don't think you'd have to treat it on your exam. Certainly possible, but it seems unlikely. All family members and sexual partners should be treated regardless of symptoms. And it may take up to 2 weeks for symptoms to resolve because it's an allergic reaction to the eggs that cause the itching. And then if you can remember that, you can also remember that an antihistamine or a steroid may be helpful for treating those symptoms. And again, as part of our treatment plan here, you're going to thoroughly wash all household items, including clothes, bedding, and towels. All right, so that brings us through our derm parasites. We're going to move into fungal infections. So under fungal infections for dermatology, they bring up Candida. And there's a couple places where Candida comes up throughout the topics. You can get esophageal candidal infection. You can get a vaginal candidal infection, but you can also get a skin candidiasis of the skin. 2 places where this happens is with diaper rash, right? With diaper dermatitis. So you can get a secondary infection. This is following several days of severe diaper rash. So 3 or 4 days, you get a bad diaper rash. You can get a candida infection on top of that, what they call a superinfection. Recurrent infections may be a sign of diabetes type 1, which can increase your chances for getting a candida infection. Clinical presentation, red plaques of satellite lesions. Satellite lesions is the key term here. Anytime you see a diaper rash with satellite lesions, that's Candida on an exam until proven otherwise. The other thing that stands out here is they primarily involve the skin folds. So it's not just open skin, but it's where the skin folds over, like the groin, that sort of area. Labs and studies, the diagnosis is typically clinical, although you can do a KOH prep with pseudohyphae, which is your key term there for diagnosis of Candida, or a culture will confirm the diagnosis. Treatment here, antifungals. Steroid cream is not recommended for infants, especially in the groin area. It is not okay, much too sensitive. Intriginous dermatitis is the other place where you see this. So what this is, it's a common inflammatory condition of skin folds. This is when you get erythema, malodor, weeping, pruritus, and tenderness, and it's caused by moisture in deep skin folds. So what you're thinking of is a obese patient with a big pannus underneath that pannus, or is one place where you may find this because of that moisture buildup in the skin rubbing together. So risk factors include obesity, poor hygiene, and immunodeficiency. The clinical presentation here will be beefy red patches, and the most common locations are the axilla, inframammary folds. So again, patients we go in to do breast reductions on sometime because they have these very large pendulous breasts, and you can get this dermatitis beneath the breast where the skin rubs and it's very moist all the time. In the groin, beneath a large pannus. And then again, the satellite lesions are an indication of Candida. This diagnosis is typically going to be clinical, but one more time you can do a KOH prep here, and pseudohyphae, seeing those will be an indicator for you, or a culture to confirm the diagnosis. Treatments, cleansing and drying of the affected area. We had a patient some time ago who was coming in for a shoulder surgery, and she wound up, when I went to go see her before the surgery and to check in on her, she was actually getting a total shoulder done, if I remember correctly. It was a while ago. And when I went to go in to see her to make sure everything was okay and do her pre-op, update her history and physical, and make sure we're going to go ahead with everything, she showed me a nice rash she had on the armpit of that particular arm, and it was most likely this type of rash, and hard to say whether they had on top of it a fungal infection or not. We wound up canceling the surgery because of the risk of fungal infections for her, but the cause of it was that she couldn't really raise her arm up because her shoulder was so bad. So you get this very moist area of skin rubbing together, and that's what we have here. So in this patient, actually doing the surgery would have helped her to avoid this type of infection, but now she's going to have to try and clear that up before she has surgery. So weight loss will help. Things like breast reduction surgery will help. Things like abdominoplasty or paniculectomy, antifungal cream like ketoconazole or clotrimazole, those will help to clear it up as well. Again, I don't think this is something I would spend much time on if I were you. The diaper rash thing seems to come up from time to time. Know that Candida is a secondary infection for the skin. And if you're immunocompromised or have diabetes, certainly you're at an increased risk for it. But that's about as far as I would go there. Next, we have dermatophyte infections, so ringworm. A fungal infection affecting the skin, hair, and or nails. Infections are described by their locations. Tinea pedis is the foot, athlete's foot. Tinea crurus is the groin or jock itch. Tinea corporis is the trunk, legs, arms, or neck. Tinea barbara is the beard area. Tinea ungum is in the nails, an infection in the nails. Tinea manum is in the hand. Tinea facialis is the face. And tinea capitis is the head. Clinical presentation here is a raised red ring with a central clearing and distinct borders. Again, I'd just pick up an image of that. It's pretty easy to recognize once you see it. The patient winds up with itching, stinging, and burning. If it's located between the digits, you can get maceration. In the scalp, you can get broken hair shafts, so this can lead to baldness, and it's something you should look at when you have a patient come in with new onset baldness, is to make sure that they don't just have a fungal infection. Labs and studies, this is often a clinical diagnosis, but again, a KOH prep can work to diagnose this. And a Woods light may be helpful. And as usual, you can culture this, but probably not the way you're going to start off. Treatment, mostly topical creams, ointments, lotions, sprays, and powders. And as we talked about before, nail infections can be difficult to treat, and there are oral medications, but those do have certain liver toxicities. You're not going to give any steroids for this. They initially cover up the redness and make things worse in the long run. You want to keep the area clean and dry. For example, if you have athlete's foot, you're going to want to change your socks frequently, right? You don't want to be in sweaty, yucky socks all day. Keep the area clean and dry. Pityriasis versicolor or tinea versicolor. This is a chronic fungal infection. And this is definitely something I would take a look at the pictures of, because it's a very distinct presentation. It's a rash mainly in the upper trunk and proximal extremities. There are tan pink macules that do not tan. They have very clear borders. So you can see these as like hypopigmented circles that eventually mesh together and create bigger areas. But they've got clear borders. They're mildly pruritic, and the symptoms tend to be much worse for people in hot or humid climates. KOH prep here reveals round yeasts with filaments, giving a spaghetti and meatball appearance. As far as treating this, it's difficult, and it can be, there's a high recurrence rate. So you can do some topical lotions, so selenium sulfide lotion, 2.5% for 7 days, and then repeat as necessary. Ketoconazole shampoo used weekly. You can also use systemic antifungals, like ketoconazole, 200 milligrams daily for 7 days. What I thought was interesting here is it's delivered through the sweat to the skin, so they ask you not to shower for 8 hours after taking it. And then there's fluconazole, 300 milligrams, 2 doses, 14 days apart. Again, I don't see you getting beat up with treatment plans here. I don't see that as a major question. I definitely see diagnosis for dermatological issues. I see a lot of good questions they can ask based on diagnosing these. And there's some things that they could ask as far as treating them, general categories for how you treat things. But I don't see them being real specific, asking for doses and things. That just seems like it's more depth than I would study for this. Not to say it couldn't come up, but it absolutely could. As always, I'm trying to give you what I think is the most relevant information for your exams, not the deepest understanding, not necessarily the best treatments, not necessarily every little detail. That's certainly not what this show is about. This show is about getting you the information that will be most helpful to you in passing your exam, but certainly not every single detail. I had somebody email me a couple weeks ago that they were listening to an old show, and I left out a particular sign for the diagnosis of it. And that happens, absolutely. I'm not saying it doesn't happen, or sometimes I do it by mistake, but a lot of times I leave out the bulk of the information you would find in something like Cecil's for sure, or Current, or any of those, and try to just whittle it down to the finer points that I think you really, really have to understand. And we're trying to create a solid base of knowledge, one, for your exam, but two, for your general walking around knowledge. I think if you have too many details, it's difficult to maintain all that information. So I think just hanging on to the most important things, and then being able to build the rest of it from your brain and the way that you think is kind of what I'm expecting. So for example, if we're talking about fungal infections, I hope that you understand that things like fluconazole or ketoconazole would be treatments for that. I don't think you need to memorize it for each and every single fungal infection, right? Exactly what the dose is, exactly what the administration is. But I think you should be able to pick out what a antifungal looks like, and it's not a normal antibiotic, and it's not an opioid, and it's not a beta blocker. You should be able to pick out what a antifungal medication looks like, and not necessarily be able to choose the best antifungal out of a group, but be able to choose out of a group of random medications the antifungal if you can diagnose it. I think that's what's the level that's going to be expected of you, or at least that's what I studied for my exam. All right, so we're going to move on to our actual study tip. That wasn't it, but I do have a study tip for you today, and this is also based off an email I got from a community member, and they reached out to me and they said, "Geez, I'm studying for my PANRE. I'm due up this year, and I have no idea where to even begin. What do I do? How do I start? There's so much to know, and I don't even know where to begin." Well, first of all, to send me that question, I could write back 10 pages. In fact, I could do a whole issue of physician assistant exam scholars on that exact question. It's a tremendous question. It's huge. But for me, the easiest place is to follow Stephen Covey's advice. And Stephen Covey is the author of The 7 Habits of Highly Effective People. If you've never read it, it's really pretty good. I think it's worth your time and effort. It isn't a bestseller for no reason at all. I would definitely check that out. I think it's very valuable. But anyway, one of his habits was the idea of beginning with the end in mind. And this is a practice I love and I use all the time. So the question isn't, what do I do? Right? It's not, where do I begin? It's, where am I trying to go? What's the end point? What am I trying to achieve? So you're looking down the road. You're looking at, in this case, this individual is looking at their exam. So they say, okay, I've got to take my PANRE by the end of the year. Then, and what they want, and what Stephen Covey wants you to do at that point is decide on what that end goal is, that end point, and then work backwards from there. Decide what you need to do to get to that point. So what he means by that is, so just let me learn through an example with you so you can understand, or you can see it more clearly. If you want to take your PANRE at the end of the year, your first step is to pick an exam date. When am I going to start studying? Or when am I not start studying? I'm sorry. When am I going to take my exam? What's the date I'm going to take this test on? So you pick a date based on whatever works for you. So let's say you want to get through you wanted the summer to study, which sounds terrible, but that's what you want to do. So you register and you look at the dates and you pick September 27th. Sounds good. So you pick September 27th. You say, okay, I'm going to take my test on September 27th. Then you start to work backwards. So what does that mean? That means you have to study all this information between now and September 27th. They give you the blueprint. They give you all the topics and everything you need to know to study for this exam. So then what you do is you start to work backwards and you start to plug in when you're going to study what material. I'm going to start cardiology in June. I'm going to study ENT in July. I can probably get through 2 things in July because July is pretty long and ENT is pretty short. So let's do dermatology and ENT in July, and so on and so forth. And you map out a plan. And then you simply walk through that plan and go take your test. So beginning with the end in mind simply means you begin with your goal, picture it strongly in your mind, attaining that goal, and then you work backwards through the steps you would need to go through in order to achieve that goal. Begin with the end in mind. And that works really well for any project. I constantly do that now if I'm trying to create something new, or if I'm trying to write a new edition of Exam Scholars, or I'm working on a project at home. It's, what do I want this to look like? How do I get there? And it's so much easier to see it when you're not worried about the first step. The first step's always scary, but if you work backwards, it's so much easier. All right, let's wrap up with answering our questions for today. These you should be able to remember from the discussion. These were pretty straightforward, pretty obvious things that you should hold on to. What are the only 2 types of spiders we need to worry about for the PANCE? The brown recluse and the black widow. What are the 3 types of lice we need to be worried about? Head, body, and pubic. And how do you diagnose scabies? Under oil immersion. Spaghetti and meatballs should make you think of what diagnosis? Tinea versicolor, also known as pityriasis versicolor. All right, sweet. That wraps up our disgusting lecture on dermatology for today. Hopefully that was helpful and you will retain the important keys from today's discussion of dermatology. And like I said, know exactly, the depth that you're going to need to know. I hope that's covered pretty clearly and makes it so much easier for you on exam day. Anyway, congratulations to those of you who emailed me this week to let me know that you passed. It's always a good time to hear that you guys have done well and things are moving forward. And good luck to any of you taking your exam this week. And I look forward to talking to you soon. Take care.